Hello, how are you?
I'm really
Uh,
good.
so, Greetings everyone, and welcome to the ISPRM 2024 interview series. I am delighted to be your host today, interviewing Professor Fary Khan. My name is Margarida Freitas, and I'm a specialist in physical medicine and rehabilitation and a PhD student from Portugal. In this video series, we will be interviewing keynote speakers of the upcoming ISPRM World Congress, which will take place in Sydney in next June. It is my pleasure and a privilege to introduce you Professor Fary Khan from the Royal Melbourne Hospital and Peter MacCallum's Cancer Centre in Victoria,
Thank you.
Australia.
Thank you very much.
If you want me to say another few words, because you are such an important figure in this ISPRM community, I would like to remember everyone that you have been elected the vice chair of the International Society of Physical and Rehabilitation Medicine last in 2022, and also you were inducted into the prestigious US National Academy of Medicine and awarded the Member of the Order of Australia. This is so outstanding that I can't not say this. And just to end up this introduction, you are also an executive member of various national and international committees, including the WHO ISPRM Liaison Committee and the UN ISPRM Liaison Committee. And also, you have been working with Disaster Rehabilitation Committee, among others. So, this is so exciting to be here. Thank you so much again, Professor Fary Khan.
It's a pleasure. Thank you for having me.
What can you tell us about your keynote lecture? Can you give us an idea of the topics you'll be discussing?
Thanks, Margarita, and thank you, everyone. I hope to see you all in Sydney for our Congress, and it's the first time we're going to hold it in Australia, and so this is very exciting for us. So my keynote lecture is the Ollie Ook lecture. Now, Ollie Ook lecture is a huge privilege. I'm totally delighted to give this lecture on an update in cancer rehabilitation titled Now or Never. And I just want to tell you about Professor Ollie Ook. I didn't know a lot about him until recently. I'm very indebted to the Swedish Academy of Rehabilitation Medicine for nominating and asking me to give this lecture. Huge privilege. So Professor Ollie Ook was apparently the founder of rehabilitation in Sweden. He was a neurologist and working at Gothenburg, and he set up the first rehabilitation training and clinics, and he also wrote one of the earliest books in rehabilitation medicine. And I think this was his practice started somewhere in 1967 or something like that. So he was a pioneering huge person in our specialty. So having a named lecture after him is unbelievably wonderful for me, as a very small person compared to his contribution. So thank you. Now my lecture is actually going to be about cancer rehabilitation and how it is a national health priority for many developing and developed countries. And it's on the agenda of everybody. And as healthcare improves globally, people are living longer, treatments for cancer are getting better, and now more survivorship issues are emerging almost as a long term condition. And therefore, it's almost like a non communicable disease, which is the cancer survivorship. And many of their issues are to do with pain management, for example, cognitive deficit following, for example, brain tumors, or massive surgery, abdominal surgery, for instance, like esophageectomies, HIPEC procedures, pancreatic resections, so high risk procedures. But people are surviving from a lot of those surgeries. And what are we doing about it from the rehab perspective? I also want to talk about the preventative element of how rehabilitation can help in the cancer cohorts. So, for example, we have prehabilitation at one of the centers where I head the rehabilitation service, the Peter MacCallum Centre. It's a Victorian Comprehensive Cancer Centre, one of the largest cancer hospitals in the Southern Hemisphere. And here we have rehabilitation completely ingrained within the Department of Anesthetics and also surgery, particularly colorectal surgery, for example, and others, where we look at patients who are about to go for surgery, who are not ready for surgery. They might be older, debilitated, have many, many issues, and they need to be surgically fit for their procedures and fit for surgery clinics, really they're called. And so we give them exercise prescription, we have dietetics involved to make sure they're nutritionally pumped up before their surgery. We check all the bloods, work with the anesthetists, we do cardiopulmonary testing to look at their capacity to ensure that the surgery they're as fit as possible for surgery prior to their procedure, and then immediately after during inpatient rehabilitation, and then follow up through to the community. The other element that I hope to address is how we can standardize assessment for rehabilitation in the context of not just mortality and morbidity following cancer, but also function, which, as we know, is a third pillar of health outcomes. And how are we doing that in the cancer population using outcome instruments such as the ClinFit, for instance? And I want to just share how we do that. And other things that I want to touch on are learning healthcare systems. And in those, we're looking at how do we use available technology to guide us as clinicians, as treating clinicians, to look at patients while they're in hospital and to try and follow them through to the community. And of course, long-term cancer surveillance in terms of function, having those post-discharge follow-ups into the community, looking at longitudinal data for various cancer groups and where rehabilitation fits in. It's all about survivorship. Remember, rehab medicine is all about life and living. And so, we are working also with palliative care, which is all about death and dying. So it's about how we amalgamate with our sister services to make sure the patients have best outcomes. So I hope it'll be of interest to your audience.
Yes, I'm sure it will be amazing and super inspiring because, as you said, cancer is such a prevalent disease. It's basically a public health problem, and the survivors, the cancer survivors, are also very prevalent. And it's all about quality of life. It's all about functionality. So I think this will be a very inspiring lecture for sure. And as we are talking about a little bit of public health, I would like to ask you a little bit about rehabilitation medicine in global health. Can you mention maybe some strategies to provide more equitable healthcare in different populations? For example, what should be a priority in developed versus developing countries, maybe?
So, rehabilitation has a lot to offer global health. So, in Cartagena, I gave a small preview of a lecture as one of the plenary lectures there. And essentially, if you look at survivorship, do you know in Asia Pacific, people over the age of 80 globally will have about just under 80% of those persons, sorry, 60% of those persons over the age of 80 by the year 2050. So we are looking at an aging population in the Asia Pacific region, for example. In the developing or low or middle income countries or less resource countries, access to health, including rehabilitation care, is very difficult. So the priorities for us, in my view, moving forwards to basically look at equity, fair access to healthcare, including rehabilitation, starts with advocacy. Now, we are in the perfect situation as member societies of the ISPRM to advocate for rehab medicine and create awareness amongst our peers, amongst government, amongst representatives to various WHO and other forums who have great power factor, to make sure that the ordinary person in the street is aware of what services are available in their particular areas. In the low resource countries, this is particularly a challenge because universal healthcare is not present there. And I know a lot of work is being done by many countries in this context to advocate for the UN SDG goal number 3, and also to develop universal healthcare where possible. Lots of projects are underway that I know of. So I think the other big issue for us is to look at with the advocacy comes the 4 pillars of the World Rehabilitation Alliance, for instance, and they're looking at workforce development, for instance. And workforce development is so crucial because we need tip-top rehab physicians who know what they're about and they know what to do. And it's not about using high-tech gadgets only; it's about how you can provide good care to people with as where a lot of technology and resources are not available, and that's a lot of countries in the low and middle income group around the globe. So, a well trained workforce in rehabilitation medicine practice, access to journal clubs, access to rehab literature. Not everyone can buy those expensive textbooks in rehabilitation, and having access to, for example, online training where possible, to basically have access to meetings and congresses and conferences at subsidized rates, for instance, anything that can do capacity building. Maybe have ambassadors from various societies within the ISPRM who can go to neighboring countries that might be struggling and assist their workforce in courses development, research education, curricular development, for example. And I know that ISPRM societies have in the past done a lot of work to have a more global curriculum for our member states and societies. So that's one element. The other element is all about governance and how we look at evidence based practices, for example. How do we deliver health services in an equitable manner? Because it's about not using sort of, even when you don't have the resources, you can still provide relatively decent care. And many people that I see around in the Asia Pacific region have done so wonderfully with so little, and they're to be commended. But they need to be more supported, I guess, by our societies within the ISPRM membership. There is also a lot of focus on primary care, preventative elements, where we are looking at the outside the community, outside the hospitals, in the community care, where patients ideally should, where possible, be managed in the community so they don't end up in the hospital. And what are we doing to have those such programs that allow health promotion, for example, preventative elements, and therefore, reduce the presentations to hospital. So, for example, people have asthma action plan if they have asthma, so they don't keep presenting to hospital. In our hospital, for instance, we have a COPD action plan or an MS patient action plan. Should they get sick and unwell, if they have a UTI, what should they do, rather than just presenting straight up to a hospital emergency department? So little initiatives like that. And last but not the least, working with GPs, your general family practitioners. So, having that element in the community where we can work and integrate better with our general practitioners. And I know a lot of work is being done in that context as well. And last but not the least in my mind is research. And again, it's very hard to do research when you don't have mentorship and guidance. And where possible, I think if we can have some education, again, support for developing researchers, emerging researchers, that would be just brilliant. So these are just some of the ideas that I think, many of our members are doing. They're doing it in ad hoc way, and perhaps we need a platform for people to come together, have a group of ideas, mull over those ideas. Some are good, some are not so good. Some we can do better together rather than isolation, and have a sort of joint strategy moving forward, like a forward moving plan to implement the mission of the ISPRM.
Thank you so much. We all have so much to learn from you. That's very inspiring. And now, in a less formal tone, I would like to ask you, how does it feel to receive the ISPRM community in Australia? It's the first time. How are you feeling?
Well, it's very, we're so excited. I can't tell you. We are so excited. And we bid a number of times and we were only successful this one time. And it takes 20 years to advocate and try and gather your resources to do a congress like this. So we are very happy to have all our friends visit Sydney. It is a beautiful city, and it's worth having a few days before or after the congress to enjoy the city and the people. Sydney has a beautiful food culture. They have fantastic sort of areas around Sydney. The beaches everybody knows about, but there's also mountains around Sydney, Blue Mountains they're called. So if you have time, try and spend some time there. The Congress itself is, the scientific committee meeting was just half an hour ago. And look, we've got about 80 odd workshops alone. It's the largest number of workshops, at least in my mind. And there's a huge range of themes that hopefully will attract everyone. There's something for everyone. And we also have discounted scholarships for people from developing countries. And those of you who have not applied, please apply. The details are on the ISPRM website. We've also got hints for people which airlines to take, for example, which is the cheapest way to get here, how to get visas easily, how to do group bookings for discounts. So a lot of that information is on the ISPRM Sydney website for 2024. So please have a look. Thank you.
Thank you so, so much. And it was a huge honor and a privilege to be interviewing such an important figure in global rehabilitation. Thank you again so much, Professor Fary Khan. And thank you for this interview. And see you in Sydney. Bye bye,
Absolutely.
everyone.
Thank you, everyone. Bye bye.
Bye bye.